Okay, so today we're going to cover chapter 21, 22, and hopefully 23. I know that it's July 3rd, and you guys are getting ready to have a cookout or something. So let's go ahead and get started. And I believe the next chapter is going to be environmental emergencies or something like that. Like, toxicological emergencies, I'm sorry. And then the other one would be abdominal emergency, abdominal. So let's see if we can get through at least a couple of chapters, and then we'll play the catch-up game. So anaphylactic reactions, just basically anaphylaxis is a severe form of allergies. Give me a few seconds, please. Okay. So allergic reactions, a hypersensitivity reaction, and basically your body's working too good for you. So an anaphylactic reaction, also known as anaphylaxis, is a severe, life-threatening allergic condition. So let's see, an allergic reaction would be itchy eyes, uh, itchy skin, welts, or whatever. The anaphylactic version is the one that drops your blood pressure and closes up your airway. Okay, a delay in treatment can actually result in death. I mean, if your blood pressure is 0, you're not getting perfused, so your brain starts going to get affected, and of course, the organs in your body are going to start getting affected. The immune system responds to foreign substances called antigens, allergens. Now, antigens are whatever penetrates your body that's not supposed to be there. Okay, like pollen and just to talk about simple little things. Allergens are a type of antigen, okay, and can actually provoke a reaction in some people. So what happens is your body, once it gets exposed to it, it will react to it. And the more exposures you have, the better your body gets. And sometimes it gets overexcited to where it kills you. Your own body's killing you because of these reactions. Um, so the response to the immune system upon exposure to an antigen is called antibodies. Antibodies get released, and antibodies are the ones that activate all this inflammatory hormones, also not hormones, but substances can actually vasodilate your blood vessels and all this other good stuff. So the immune response typically occurs with little or no allergic reaction. So we're talking about anaphylactic. So the body can also produce immunoglobulins, and we have at least 5 different types of immunoglobulins in response to allergens. And allergens will actually produce immunoglobulin E. Okay. Of course, we have immunoglobulin A, B, and C. Depending on which one you get, some of them will actually react to parasites. Some of them will actually react to allergens, like in this case, and whatsoever. So if IgE encounters an allergen, it triggers the immune system response. And the main chemical that we have in the immune system, uh, the mediator for inflammation in our body, is histamine. And if well, I'm not gonna get into where you're gonna find histamine, but histamine gets released, and histamine actually produces the allergic reaction, inflammation, and whatsoever. So, like when you have a cold, the reason you can't breathe is because your nasal cavity, okay, is actually swollen up because of what do you call it? Because of histamine. So, what type of medication do you take? You take an antihistamine to reverse the process. Okay, and excessive immune response to an allergen is called an allergic reaction. Occasionally, there's a severe life-threatening form called an anaphylactic reaction. So pathophysiology of the reaction, an allergic reaction, and the excessive response to an allergen is also allergic reaction. A severe systemic immune response to an allergen is called an anaphylactic reaction. So an allergic reaction is a mild form of the reaction, and an anaphylactic is a severe form. Chemicals released by the body in anaphylaxis cause airway swelling, bronchoconstriction, and vasodilation. So airway swelling will stop you from breathing. Okay, dealing with bronchoconstriction will prevent you from breathing, and vasodilation will bring down your blood pressure to where it's going to go down to very low levels, and you're not going to perfuse the right organs. Now, sensitization, on the first exposure to an allergen, sensitization occurs and immunoglobulin E is produced. So basically, let's say you get stung by a bee when you're a kid. It gets produced to recognize the V venom that gets injected to you. So the second time you get it or the third time you get it, you're going to get a more severe reaction because now your body can recognize it. After sensitization, IgE antibodies attach to two types of hormone cells, the mast cells, which are basically in the tissues, and the basophils, which are basically circulating in the blood. And basophils are the cells that circulate in the blood, and they're a type of white blood cells. We at least have 5 different types of white blood cells, and basophils as being one of them. And basophils contain these little when you see a basophil under the microscope, you get to see all these little specks in certain areas, and those are the ones that actually have histamine, and they actually release the histamine into the body. On subsequent exposure to an allergen, the allergen attaches to immunoglobulin E. Mast cells and basophils release chemicals that actually mediate the events of anaphylaxis, and the primary chemical mediator is histamine. So the king of inflammation is histamine, and you're trying to prevent histamine to do its damage. Okay, so basically bronchoconstriction, capillary permeability. Now, capillary permeability is when you have that oncotic pressure. So let's say the key thing you know is that you're going to have vasodilation, right? So let's say this is the wall of a blood vessel. And what happens, a chemical gets released into it and causes dilation of it. So it opens up parts. It kind of looks like if it's opening up because it stretches out. Now, the plasma can actually leak from the inside of the blood vessel to the outside, causing swelling. Let's say when you get stung by a bee, don't you get swelling around that area? You also get redness, you get pain, and you get itching. All those are produced by histamine. Okay. Pathophysiology, anaphylaxis, anaphylactoid reactions, non-IgE mediated reaction. An anaphylactoid reaction does not involve immunoglobulin E, but the signs and symptoms and treatment are the same as for anaphylaxis. Causes an anaphylactic reaction, anaphylactoid reaction. Remember, anaphylaxis requires IgE. Anaphylactoid does not require IgE. Allergens may enter the body through injection, like when a bee stings you. Ingestion, like when you eat something, like if you're allergic to shrimp, you eat shrimp, guess what you're going to have? An allergic reaction or an anaphylactic reaction, depending on how bad you're going to get it. Inhalation, you might actually breathe in the chemical or by contact. Like when you get, we don't have it here, the plant, but when you get the, I forgot the name of the plant, which is a poison ivy. Yeah. Causes anaphylactic reaction or an Anaphylactic and anaphylactic reaction. Common types of allergens include, okay, antibiotics. Now, antibiotics. I know that sometimes when you take a large amount of antibiotics, your body's going to react to it. But when you give an intramuscular injection of antibiotics, you normally put the syringe in and you pull it out to make sure that blood doesn't come out. Because if you put blood, you're not doing intramuscular, you're doing intravenous. So you're putting it directly into the bloodstream. You're supposed to put it in the muscle because it's supposed to be slow release. Now, because sometimes that happens, you actually get a reaction by the body. Okay, so antibiotics, penicillin, vancomycin, Bactrim, sulfatrim, which is basically most of the sulfa drugs, cephalosporins, tetracycline, aminoglycosides, sulfonamides, and actually amphotericin B and nitrofurantoin are some of the common antibiotics you're going to get. Local anesthetics also, like procaine, lidocaine, tetracaine, and benzocaine, and novocaine. And a lot of these are actually used, believe it or not, for topical anesthetic, or whenever they're doing teeth work on you. Opiates, opiates like fentanyl, all this other good stuff, right? Hormones like insulin and progesterone. Now, I was really freaked out. I had a patient that stated that he was allergic to epinephrine. I got freaked out because, well, isn't epinephrine the stuff that we give in order to reverse the anaphylactic reaction? And it is. It's one of them. Okay. But this guy was, we figured out that he was not allergic to adrenaline. He was allergic to the man-made version of it, which is, what do you call it? Epinephrine. So hormones like insulin and progesterone, steroids, also vitamins like thiamine and folic acid, and angiotensin converting enzyme inhibitors. Also, as this is the ones. These are the captoprils and enalaprils and all these other anti-hypertensive medications. Aspirin. People can actually be allergic to aspirin. Non-steroidal inflammatory drugs, or also known as NSAIDs. Oh, actually, this is wrong. It's non. I was really freaked out. I was like, non-steroidal inflammatory. We don't. When we give an NSAID, it's to reduce the inflammation. So it's non-steroidal anti-inflammatory drugs. Okay, so the word anti is here because they go against inflammation. Radiographic iodine-based dyes. Now, I don't know if you know this, but if you're allergic to shrimp, it's not the food itself; it's the iodine that is in the shrimp that you're allergic to. Uh, Protamine, like heparin antagonist, polysaccharides, skin creams and cosmetics, vaccines, blood transfusions, and food like peanuts, nuts, eggs, shellfish, whitefish, wheat, and soybeans. Okay, red dye, sulfite additives, which is like, dude, that the red dye, sulfite additives is in everything. Skittles. I mean, a lot of the candies and a lot of the Doritos, and I remember Doritos being one of them. Uh, but that actually it's an additive that they actually put on the on foods. Insects like hornets, wasps, fire ants, scorpions, caterpillars, kissing bugs, centipedes, millipedes, and arachnoids like ticks. Marine life like the sea needle, man-o'-war, or jellyfish. The man-o'-war is a bigger version of the jellyfish itself. Mammal bites like rats, mice, gerbils, and hamsters. Environmental like mold, pollen, or cold. Latex, like in the gloves that you guys wear. Perfumes, exercise. If people are allergic to exercise, uh, but it's just that you get allergic to things in your environment also. So, and sometimes we don't know what the hell you're allergic to, but you're allergic to something. Okay, so basically, click on the column below. that is responsible for decreased perfusion related to the effects of histamines, weakening and failure to the left ventricle of the heart when it comes to anaphylactic reaction, obstruction of blood flow through the pulmonary arterial system, vasodilation and loss of fluid from vascular space, or inability of cells to actually use the oxygen that is delivered to them. So what do you think it is? Let's see if you guys were paying attention. Can you ask the question again? What's right there? It says, which is responsible for decreased perfusion related to the effects of histamine in anaphylactic reactions. So basically, what brings down the blood pressure when you're having an anaphylactic reaction? The mechanism. Well, it would be vasodilation of and loss of fluid from the vascular space, because that brings down the blood pressure. So it's letter C. Okay. Assessment-based approach for anaphylactic reactions. Anaphylactic reactions is often apparent because of the characteristic signs and symptoms. In the scene size up, be aware of the dangers such as wasps and bees. And the type of setting and medications at the scene can actually provide some clues at what they might actually be allergic to. Do a general impression, maybe like malaise, which is kind of a weak look, general discomfort, and sense of impending doom. Now, the sense of impending doom is because the blood pressure has dropped already. Mental status may actually be alert to unresponsive, have a high risk of airway obstruction, and you might actually develop stridor, crowing, which is indicative of upper airway swelling. So stridor is an upper airway issue, and crowing is also an upper airway issue. So if that reaction is in your upper airway, then you're gonna have these strange sounds. Airway adjuncts will not help laryngeal edema. So the larynx gets swollen up, putting stuff in there is going to irritate it more. Wheezing may actually be prominent. Positive pressure ventilation may be needed. Maintain SpO2 levels at 94 or greater. Ventilations may actually be difficult from an increased airway resistance. So once the airway starts closing down, you might actually have a hard time trying to ventilate them with a BBM, because you're going to have a smaller air space for you to actually put that air in. So you're going to find some resistance. Consider an ALS backup for airway management. The pulse may actually be weak and rapid. There may actually be edema, and the skin may actually be red and warm or cyanotic. Hives and itching are characteristics. And we're going to go over the different names that we use, the medical terms that we use for hives and itching in a little bit. Now, this is a localized angioedema of the tongue. Now, I can guarantee you this lady is allergic to shrimp, and she decided to eat shrimp. That here is not her lower lip. This is her tongue. The tongue can actually grow so much that it might actually close up the airway. Hives, also known as urticaria. Okay, these actually look like little blotches in the body that actually appear on the skin. And one thing I remember is that what you see outside is inside the body too. So you get all these little splotches of a reactive tissue. Hives from a food allergy, they can actually develop. Now, I get to see one right here in this little section here. I get to see maybe just another one that'll right around this area. But you get the blotches. Okay. Assessment-based approach for anaphylactic reaction. Remember, urticaria is also known as hives. Okay. Pruritus, right here. This is itching, guys. It's just a 25-cent word for itching. Okay. Signs and symptoms include rhinitis, which is inflammation of the nose, tachycardia, because of loss of blood pressure, your heart rate goes up. Pruritus, which is itching, and faintness, because of lack of blood to your brain. Excuse me. Signs and symptoms also include warm, flushed skin, may actually be pale, agitation and anxiety, urticaria, which is hives, and edema, which is swelling. Be prepared for an immediate intervention and transport. Determine whether the patient has an epinephrine autoinjector. And most people that have allergies will have an epinephrine autoinjector. So let's see, you have rhinitis. The signs and symptoms that are going to show up are nasal congestion, itchy nose, sneezing, swollen nasal mucosa, and runny nose. The pathophysiology, you have an increased capillary permeability, which causes vasodilation, and it stimulates and stimulation of the nerve endings also. Laryngeal edema, which is you're going to find stridor, dyspnea, hoarseness, tightness in the throat, and excessive salivation. The pathophysiology is you have an increased capillary permeability, vasodilation, and stimulation of the nerve endings. Increased bronchial airway resistance. Now, when bronchioles actually swell up, they close up the airway. So you're going to have a resistance. Oh, the hell did I do? Okay. So you're going to find wheezing, bronchi, cough, dyspnea, tightness in the center of the chest, tachypnea, respiratory distress, and cyanosis. And again, you have increased capillary permeability, vasodilation, stimulation of nerve endings, and bronchial smooth muscle contraction, which closes up the airway. Cardiovascular collapse and poor perfusion. You develop tachycardia because your blood pressure goes down, so your body's trying to compensate. Hypotension, syncope, lightheadedness, general weakness, and syncope, and chest pain. And the pathophysiology would be increased capillary permeability, vasodilation, stimulation of nerve endings, and bronchial smooth muscle contractions, and increased venous capacitance. Skin edema, which is swelling around eyes, mouth, and extremities. You have an increased capillary permeability, which basically causes the swelling. Eye conjunctivitis, which is basically when your eye turns red. You're going to have an increase in tears, itchy eyes, and swelling to the eyes. And basically, this is caused by stimulation of nerve endings themselves. Gastrointestinal, you're going to get cramping, abdominal pain, nausea, vomiting, diarrhea, difficulty swallowing, also known as dysphagia. Feeling of constantly having to move bowels, which is also known as tenesmus. And it's like if you want to go to the restroom, but you don't. Have an increased mucus secretion and gastrointestinal smooth muscle contraction. Central nervous system, you have anxiety, apprehension, headache, sense of impending doom, and confusion. You have cerebral hypoperfusion, in which your brain's not getting enough blood. Hypoxia, not enough oxygen, secondary to vasodilation. You have an increase in capillary permeability and bronchial constriction, which is lowering the amount of blood that's going to go up there and oxygen that you're supposed to take in. In the genitourinary, you're going to have urinary incontinence, vaginal bleeding, and pelvic pain. Now, the urinary incontinence, what is that? What's the word incontinence mean to you guys? When you pee yourself. It's caused by uterine smooth muscle contractions and bladder smooth muscle contractions. Okay, assessment-based approach to anaphylactic reaction. Secondary assessment for the history of present illness, use OPQ-RST. Time is critical generally. The more quickly the reaction develops, the more severe it will be. So the faster you get the reaction, the faster you're going to die. Assessment-based approach. Secondary assessment determined the following. Are signs and symptoms consistent with anaphylaxis? Are signs and symptoms mild, moderate, or severe? Are signs and symptoms getting worse or better? Determine the following. Does the patient have a history of allergies or anaphylactic reactions? is an epinephrine auto-injector prescribed to the patient? Any other medications that they've taken, like Benadryl and all these other good ones? And what medications is the patient taking for these type of reactions? They might actually be taking Alevert or any like allergy type of medications. Determine the following. Has the patient had an anaphylactic reaction in the past? How severe was the last reaction? And does the patient have other illnesses like diabetes or heart conditions or whatsoever? Determine the following. Did the patient last eat or drink? Remember, that's part of your OPQRST and your sample. So when was the last time the patient ate? That might determine what might have actually given him that reaction. What he recently eat or drink, also activities prior to the onset of the reaction, like was he running, was he outside cutting grass, or what? Was the patient exposed to anything that could have caused the reaction, like bee sting or whatever? Secondary assessment, signs and symptoms. The skin. You're gonna have flush skin, red skin, whatsoever. You might actually develop hives. Respiratory system, you have a bronchial constriction occurring. Cardiovascular system, you might actually have a collapse in the cardiovascular system because the blood vessels open up, dropping up the blood pressure. Central nervous system, remember you're going to have, with the central nervous system, you have syncopal episodes. Um, Part of the itching is actually caused by the central nervous system whatsoever. Gastrointestinal and genitourinary, well, gastrointestinal, you're going to have that feeling of moving your bowels all the time. And the genital, you're going to have incontinence. Generalized signs and symptoms, which you're going to look at the patient and you're going to see maybe his ankles are swelling or the body is swelling. When the whole body swells, not just the part that got affected, but the whole body, that's called anasarca. And anasarca basically is swelling of the whole body. You don't get to see this term that often in these books, but basically, it's just body, overall body. I think it's a Z, anasarca. Okay, assessment-based approach, the anaphylactic reaction. Secondary assessment, always obtain a baseline vital signs. You might actually get hypotension may actually be present, respiratory may actually be fast or labored. Wheezing may be heard without a stethoscope, and the pulse may actually be rapid and weak. Emergency medical, emergency medical care. Emergency medical care. Sorry. Distinguish between a systemic and local reaction. Now, how can you tell the difference between a systemic and a local reaction, guys? Systemic is the whole body, and local is just where they actually stung you. Treatment depends on this distinction. Okay. Uh, Emergency medical care, two key categories uh, of signs and symptoms: airway and respiratory compromise, and shock. So basically, when it comes to anaphylactic reactions, you're going to get airway problems and you're going to have cardiovascular problems. Now, the severe systemic anaphylactic reaction, you have acute onset, which it happens very fast with involvement of the skin, mucosal tissue, or both. You're going to develop hives, itching, flushing, redness, edema to the face, lips, and tongue. And signs and symptoms of respiratory distress, like dyspnea, wheezing, stridor, and SpO2 level less than 94%. Now, what does the word dyspnea tell you? What is dyspnea, guys? Hello? Dyspnea, difficulty breathing. Okay. You have signs and symptoms of poor perfusion and hypotension because of the loss of blood pressure. Okay, emergency medical care, maintain an open airway. Use airway adjuncts may if you decide to, but they might not work because if the throat is swollen up, no matter what you do with the tongue, it's not going to help. Suction secretions, they're going to be salivating a lot and maintain an SpO2 level of 94 or greater. Emergency medical care, be prepared to provide positive pressure ventilation. Administer epinephrine by prescribed auto-injector according to protocols. Now, I don't know what protocol you guys have, but the epinephrine auto-injector is great, but people are starting to go back to the old-fashioned. They're carrying the little vials of epinephrine, and what you need to do is you're going to get a syringe and suck 0.3 milligrams of for an adult and 0.15 for a child. But you're gonna have to, break the vial and then suck it out and then inject them that amount. Consider requesting ALS and initiate transport early. Now, if the person has their own epinephrine pen, inject it. Okay, and then I'll show you the steps on how to do this. Reassessment. Look for medications or mild to moderate reactions in progress. Is progressing, I'm sorry. Monitor the effects of the treatment. Closely monitor airway, breathing, oxygenation, and circulation, and reassess for vital signs. You can actually have an approach for anaphylactic reaction. You have a biphasic and anaphylactic reaction. 20% of the patients experience this anaphylactic reaction and they have a biphasic or late stage. So they might have a mild form and say, well, they're doing fine. You let them go home. All of a sudden, boom, they get the severe form. So summary of the assessment, prompt treatment for allergic reactions are critical to positive outcomes. Epinephrine auto-injector. Now, epinephrine mimics the effects of the sympathetic nervous system to treat the signs and symptoms of anaphylaxis. If alpha-1 effects causes vasoconstriction, beta-2 effects causes bronchodilation. So it affects both of these. They also affects beta-1, which affects results in side effects, which you're going to have like nervousness and whatsoever. The effects of the epinephrine are rapid but short term, so they're good for about 3 to 5 minutes. The auto-injector may actually be packed singly or in pairs. There are 2 dosages, 0.3 milligrams for adults or anybody above 66 pounds, and 0.15, which is half of that for anybody weighing less than 66 pounds. And this is what the auto-injector looks like. It's got the part here where you're going to have the needle coming out, and then you're going to have that protective cap that you need to remove so you can actually get it. Do you guys carry the auto-injector in your unit, or do you carry the vials? Okay. Well, we'll figure it when you guys wake up. If the patient has more than 1 injector, transport the second injector device with you. The dose can actually be repeated 5 to 15 minutes after it's needed. The side effects of epinephrine: increased heart rate. Well, they're giving you adrenaline, so it's going to increase your heart rate, right? You're going to have pale skin, dizziness, chest pain, headache, nausea, vomiting, and excitability and anxiousness. Administration of O2 by non-rebreather mask. Check the expiration date. Make sure it's for that patient. Whatever. So you're giving them oxygen already so they can breathe a little bit better. Notice that the position this kid is in, he's in a tripod position. Remove the end cap. You press it firmly against the skin, and then you pop it in and leave it there for, I think it was 10 seconds. And once the 10 seconds is up, remove it and then do away with it. Put it in the sharps container. Questions? Okay. Now this chapter is in toxicological. Let me see if I can. Where are you guys? No, I pressed the wrong one. Hold on. Okay, so this is environmental. Oh, this is, I'm sorry. This is went back to anaphylactic reactions. So now we're going to be sharing this one. Where are you guys? Okay, there you go. Chapter 22. Yeah, my system's acting up. So give me a few seconds. There you go. Can y'all see this, guys? Toxicological emergencies. Okay. Poisonings may actually be accidental or intentional, or somebody might actually try to commit suicide, and they ingest poisons. Many calls to poison control centers involve children. There are special problems associated with drugs and alcoholic emergencies also. So we're going to talk about alcoholism and whatsoever, and drug abuse. Poisons and routes of exposure. Poison may actually be a substance that actually impairs health to cause death by its chemicals. Most poisonings are accidental and involve young children. Other causes of poisonings include suicide and homicide. Toxicology is the study of toxins and antidotes, and you actually also have to know about overdoses of drugs and medications, which is a type of poisoning. Poisons can actually enter the body through four different routes. Ingestion, which you're going to eat, you're going to be breathing it in through inhalation. Injection, you're going to inject it in, and you're going to absorb it through your skin. Now, why this little girl would actually want to drink uh, kerosene, because this is a lamp. I know kerosene sometimes is red. Um, Maybe she thinks it's Kool-Aid. I don't know. But they do that. Then we have your druggies that basically are your puffers that are ingesting these chemicals. Drug users, they inject the injection. Now, this is a tuberculin, so I guess I don't know what they use the tuberculin, the small needle ones. And sometimes you just get doused in whatever you're using. And I know in this case, they're using this powder, which kind of should be either an organophosphate poisoning or something else that you use for gardening. Poisons and routes of exposure. Signs and symptoms depend on the specific poison and the route of the entire entry into the body. Always be prepared for patients' deterioration in a suspected poisoning. Monitor the patient's mental status, airway, and breathing constantly. Remember, you can actually go down very fast. Most care for poisoning patients is supportive. In other words, keep them alive. Intervene in airway breathing and oxygenation and circulation as needed. Monitor mental status and be prepared for vomiting and make frequent reassessments. Antidotes. They have few antidotes are available depending on what you actually get exposed to. Treatment is generated towards limiting or preventing absorption of the poison and treating signs and symptoms. So you're going to be going over treating symptomology of the patient. So if he's not breathing, you're going to breathe for him. If he has a low blood pressure, you're going to try to increase that blood pressure. Let me ask you guys a question. How do you raise the blood pressure in a patient without medication?
You could do artificial, you could do CPR.
I'm sorry, what?
You could do CPR, can't you?
Well, if they have a heart rate, you might not want to do that, but you can lie them flat on the floor.
Oh, raise their feet, raise their feet.
Yeah, elevate their feet. And that'll work. That's one of the ways. And your stretchers have all these mechanisms to where you can actually do a Trendelenburg's, but you can elevate the whole body. Always determine when the substance was actually ingested, because a lot of times they'll once you get to the hospital, like I've seen people that try committing suicide by taking an overdoses of aspirin. Um, I know I saw the weirdest one. This guy took an overdose of birth control pills, which, I mean, people will try to kill themselves. But you have to know how many pills they took. So let's say they took an overdoses of aspirin. Look for the container and see if there's any on the floor and collect them, or there's any left in the bottle. Because then you have to, if it's a 100 pill bottle, you have to subtract the ones that you don't find, and whatever I mean, the ones that you found, whatever you have left is how many he took. Presumption. You have to be presuming that. Always determine when the substance was actually taken. If it was taken more than 30 minutes, chances are you might not be able to stop it from getting ingested. Commonly ingested substances, over-the-counter medications, illegal drugs, and household products and cleaning agents. You actually have foods like spoiled or underprepared, and this is when you start dealing with botulism. Insecticides like organophosphate poisonings, petroleum products, plants, common accidental ingestions, medication sometimes, medication taken with alcohol, which increases the absorption of the medication. Of course, we store all the medications at the eye level of the kids, so be very careful. Just see size up, do a primary assessment, secondary assessment, take a history, do a physical exam, check for signs and symptoms, and reassess these patients. Okay. Signs and symptoms, take a history of ingestion, swelling of mucous membranes of the mouth, nausea, vomiting, diarrhea, and altered mental status. Now this kid probably got a burn to one of the chemicals that they might have actually taken. Signs and symptoms: abdominal pain, tenderness, burns or stains around the mouth, pain in the mouth area or throat, usually breath or body odors are present, respiratory distress, and altered mental status. You might actually have an altered blood pressure, which might actually be very high or very low, depending on what medication that they took or what drug they took. Dilated or constricted pupils, warm and dry or cool and moist skin, altered mental status. They might actually be in a coma or they might actually be seizing actively. We do have this medication that's called activated charcoal or Actitor, depending on what you have. And I know that I always brag about the different flavors that they have it in now. Many occasionally may actually occasionally be used ingestion and certain substances. It absorbs certain toxins, preventing them from actually being absorbed into the body. And there's usually no evidence that that they might actually improve the outcome, but it actually prevents more from being absorbed. Because activated charcoal, all it is charcoal, carbon. And what it does, it lines it lines the whole wall of the small intestine and large intestine. So whenever you get to the point where you're gonna get to absorb it, if it's lining the wall, it doesn't get to absorb whatever poison you have. Okay, and it's actinose aqua is basically you put this in a cup and have them drink it. Maintain the airway, protect it from aspiration, assist inadequate ventilations, maintain oxygenation, prevent further injury, and transport the patient immediately. Okay, because you don't know what reaction the patient is going to have. Consult medical direction or poison control center uh, with using activated charcoal, uh, and bring the substance to the hospital and reassess frequently. Remember, these type of patients is every 5 minutes. Many poisonings from the inhalation occur as a result of fire. These poisons are rapidly absorbed into the body, and the longer the patient is exposed to the substance, the worse the prognosis for this patient. I'm talking about when it comes to poisonous vapors or fumes. Common inhaled poisons: ammonia and chlorine gas, sulfur dioxide, industrial gases, carbon monoxide and carbon dioxide, fumes from liquid chemicals and sprays, solvents used in dry cleaning, degreasing agents, or fire extinguishers. Okay. You have intentional inhalation of certain substances, such as propellants, like when you do puffing or huffing. I'm sorry, not puffing. Huffing can actually result in the displacement of oxygen from the lungs and can actually be toxic, have a toxic effect, and cause damage to the alveoli. Assessment-based approach: inhale poisons, do a scene size up, primary assessment, secondary assessment, take a history, do a physical exam, and look for signs and symptoms, and then you reassess the patient to see if your treatment is actually working. Protect yourself. Now, firefighters will actually wear a device called an SCBA, which is self-breathing apparatus, self-contained breathing apparatus. But you have to be trained on how to use these devices. Administer oxygen to the inhaled poison patient so you can try to displace some of the poison from the lungs. Signs and symptoms: take a do a history of toxic inhalation, difficulty breathing, chest pain, tightness, burning in the chest or throat, coughing, stridor, wheezing, crackles, and hoarseness. Look for signs and symptoms: confusion or altered mental status, oral or pharyngeal burns, copious secretions, in other words, they're salivating a lot, headache, dizziness, and seizures. Look for nausea, vomiting, paint, glue, or chemicals on face or lips, and signs of respiratory tract burns, like in singed hairs, nasal hairs, soot, or sputum, or throat. Uh, Protect yourself. Use an SCBA, which is self-contained breathing apparatus. Get the patient out of the environment. Place the patient in a position of comfort, and ensure an open airway, and maintain as needed. Minister 02, by non-breather mask for adequate breathing, regardless of the SpO2 level. Use a positive pressure ventilation if you have inadequate breathing, which is your BBM. Bring all information available about the substance to the receiving facility, and then reassess the patient frequently, every 5 minutes. Question: the person who meets the ambulance urges you to actually to hurry, saying that the patient is not responsive and seems to be having difficulty breathing. Click on the first action you should take. Open the airway, obtain information from the nature of the toxic exposure, begin positive pressure ventilation, or remove the patient's clothing and decontaminate them. Which one would it be?
Okay.
You can open up the airway. Now, you can
I thought
argue
it
this
was,
one. Go ahead.
I mean, are you assuming that C is like with oxygen? Because shouldn't you just, the first thing you do is give them oxygen?
Well, we don't know. We don't know if the patient is breathing normally, but if the airway is closed, let's say he has an obstruction, would you be able to do positive pressure ventilation?
No.
Now, the other thing you can think about is self-preservation. Okay, your own personal safety. Obtain information about the nature of the exposure. That could be the answer too. Because think about it. Is the scene safe? What's the chemical? Of course, the other one will actually to remove the patient. Eventually, you're going to do that. But I would go with maybe just opening up the airway first. But if I start getting real nitpicky, I would obtain information first and then go and deal with a patient. Assessment-based approach, injected poisons. The scene size up, do a primary assessment, secondary assessment, take a history, physical exam, and check for signs and symptoms. Then you reassess. This is a rattlesnake bite without the erythema showing up or the redness. Signs and symptoms: dizziness, chills, fever, nausea, vomiting, and euphoria. Check for signs and symptoms. If it's causing him to lose consciousness, like a sedative effect, high or low blood pressure, pupillary changes, if it gets constricted or dilated, or mixed, needle tracks, or pain at the injection site. Check for signs and symptoms: trouble breathing, abnormal skin findings, possible paralysis or swelling, and redness at the injection site. Protect yourself, maintain the airway, and be alert for vomiting. Use passive pressure ventilation if breathing is not adequate, and maintain a pulse oximeter reading of greater than 94%. Bring all available information about the substance to the hospital and transport the patient and reassess every 5 minutes to the hospital. Absorbed poisons enter to the skin and mucous membranes, can actually cause skin and mucous membrane irritation and burns. Risk of exposure increases daily. Okay. The poisons can actually cause both local skin reactions and systemic reactions like swelling all over the body. Now, what is that term that I told you? That is when you have swelling all over your body. What is that called?
Emma something. Emma or Ema.
Anasarca. Close enough.
There. No.
Anasarca. Do a scene size up, primary assessment, secondary assessment. Take a history, physical exam, signs and symptoms, and reassess. You notice how this repeats itself in every single patient? This is what you're supposed to do. And remember, if the person's not If he's not stable, then it's going to be every 5 minutes. But if he's stable, every 15 minutes. Oh, sorry. Signs and symptoms: contact with a poisonous plant, a fluid-filled oozing blisters, swelling, pain, and a rash, and itching and burning. Assessment-based approach for absorbed poisons. Emergency medical care. While wearing gloves, remove the source of poisons and the patient contaminated clothing. So this is what's, the stuff that falls on you and they might actually have it. If you start touching him and he's got a powder on him, you can absorb the same poison that he's absorbing. So wear protective equipment. Emergency medical care. Establish and maintain an open airway. Use oxygen to keep SpO2 level 91%. Use positive pressure ventilation for inadequate breathing. Remove any residual poisons from the skin as appropriate. Rinse the eyes if needed. And there's a technique for this. Constantly reassess and rapidly transport the patient. Okay. So ideally, you want to brush off most of it. Okay. And what it does, because some of these chemicals might actually react to water. So you want to get rid of, brush it off, and then basically, eventually, when you don't have that much, you can wash it off if it's feasible. When you're dealing with irrigating the eyes, make sure that when you irrigate from the middle to the side. Okay, because if you have them sideways, if it's on this side, you're going to be washing this eye, and it's going to roll up to the other eye. So now you're going to affect both eyes. So it's from the middle to this one, and then you twist the head a little bit, and then from the middle to this one. Food poisonings. It's an illness that can actually result from bacteria in food and or form of toxins released by the bacteria. Food poisonings is increasing the incidence. Common source of food poisoning is seafood. Common source of food poisonings include eggs, chicken, ready-to-eat foods, untreated water, unpasteurized milk, and fish. Common types of food poisonings: salmonella, which is found in food that's contaminated, especially meat; Campylobacter, Escherichia coli, which is also known as E. coli; and Staphylococcus aureus, which are different bacteria. Signs and symptoms include fever, blood disorders, blood in the stool, abdominal cramping, muscle cramps or paralysis, nausea, vomiting, and diarrhea, and loud or frequent loud movements, what I like to call internal farts. Okay. Follow the general guidelines for ingested poisonings. Establish and maintain an open airway. Use oxygen and keep it at 94% and above. Use positive pressure ventilation for inadequate breathing, and constantly reassess and rapidly transport. Carbon monoxide, which is something that we normally don't kneel unless somebody's going to try to commit suicide, or they're stupid enough because it's so hot, they close the garage and they leave the car running. So carbon monoxide is a form of incomplete combustion of certain fuels. Carbon monoxide poisoning is the leading cause of death from fires. Sources include furnaces, wood burning, fireplaces, heaters, automobile exhaust, and barbecue grills. Gas is odorless, tasteless, and colorless, and non-irritating. Signs and symptoms: headache, tachypnea, nausea, vomiting, altered mental status, and high but accurate pulse oximeter readings. So inaccurate, I'm sorry. What's going to happen is that carbon monoxide makes the body think that you have oxygen. So these guys sometimes are going to be cherry red. Okay. Emergency medical care, evaluate the patients from the, evacuate the patients from the area. Of the source, provide high pressure oxygen. Do not rely on pulse oximeter, and provide positive pressure ventilation if needed, and transport the patient immediately. Cyanide. Check something. Cyanide is
So,
found in many. What?
never mind.
Okay, no problem. I forgive you. So cyanide is found in many forms and can actually enter the body in a variety of ways. Found in items such as rodent poisons, silver polish, and fruit pits, specifically the peach fruit pits. It is a byproduct of burning plastics, silks, and synthetic materials. So you get to inhale cyanide whenever you go to a fire. It interferes with the use of oxygen at the cellular level, so you basically suffocate your cells. Signs and symptoms, you have early signs and symptoms, late signs and symptoms, or those seen in large dose cyanide poisonings. Check for scene safety, remove the patient from the source and the source from the patient. I would say remove the patient from the source and the source from the patient. Although he's gotten on him, then you kind of wipe it off. Open and maintain an airway. Administer airflow tube by non-rebreathing mask or positive pressure ventilation. Provide rapid transport with ALS backup or intercept. Acids and alkalis, and believe it or not, have you ever seen a battery from a car?
Yes.
You know that there's a sign outside, do not drink the water or the acid. And they do this because somebody probably has. Okay. So caustics are found in many household products, acids, which basically contain a low pH, and alkalis have a high pH. Acids burn on contact for about 1 or 2 minutes, and alkalis burn on contact for but sensation may actually be delayed and can actually last for hours. Signs and symptoms: burns in the mouth, lips, face, dysphagia, hoarseness, stridor, dyspnea, abdominal pain, and signs of shock. Emergency medical care: ensure the safety of self and others, remove the contaminated clothing from the and decontaminate the patient, maintain the airway, keep the pulse oximeter at 94% or above, and then consider ALS and rapid transport. Hydrocarbons. Now, guess what a hydrocarbon is, guys? Like gasoline. You have substances found in kerosene, lighter fluid, glue, cleaning agents, propellants, and other products. The toxic varies, and there is a risk of aspiration. Poisons actually may occur by ingestion, inhalation, or absorption. Signs of and symptoms: you have cough, choking, and crying, burns to the mouth and contact area, dyspnea, wheezing and stridor, tachypnea, cyanosis, abdominal pain, nausea, vomiting, and seizures. You're gonna find a patient, he might be in a coma, altered mental status, headache, dizziness, dull reflexes, slurred speech, and then cardiac dysrhythmias. Or so when you feel the pulse, you're gonna find an arrhythmia. It's not gonna be what do you call it? It's not gonna be regular. It's gonna be irregular. Remove the patient from the environment, decontaminate the patient, open, maintain the airway, maintain pulse at above 94%, use positive pressure ventilation if needed, and rapidly transport the patient. Methanol. This substance is found in gasoline, antifreeze, canned fluids, and other sources. It differs from ethanol, but may actually be drunk deliberately by alcoholics. Ingestion results in acidosis. Signs and symptoms, you can have altered mental status, seizures, nausea, vomiting, abdominal pain, blurred vision, dilated or sluggish pupils, changes in vision, blindness, and dyspnea and tachypnea. Emergency medical care, open up, maintain the airway, maintain pulse oximeter above 94%, use positive pressure ventilation if necessary, and rapidly transport the patient. Isopropyl alcohol, which is basically your rubbing alcohol. Found in rubbing alcohol and household products, may actually be intentionally be ingested by alcoholics and more toxic than our ethanol itself. Signs and symptoms, respiratory depression, altered mental status, abdominal pain, bloody vomitus, and signs of shock. Emergency medical care, open up and maintain the airway, maintaining a pulse oximeter above 94%, and rapidly transport the patient. Ethylene glycol. This is what we find mainly in the antifreeze for cars. Found in de-icers and detergents, but has a very sweet smell. That's why whenever you get I don't know if you notice this, you're driving and all of a sudden you've sprung a leak in your hoses. Well, that leak smells like pancake syrup. Have you ever noticed that? Or you guys never had a leak before?
Like a coolant leak?
Yeah, it smells like it actually gives you the smell of pancakes. Or yeah, because it's a very sweet smell. Now, this may actually be ingested accidentally or intentionally as harmful metabolites that affect the central nervous system, lungs, heart, blood vessels, and kidneys. First stage is neurological for ethylene glycol poisoning. Second stage would be cardiopulmonary, and third stage would actually be renal. Emergency medical care, open and maintain the airway, maintain an SpO2 level above 94%, use positive pressure ventilation if needed, and rapidly transport the patient. These plants, now poisonous plants, now I know that depending on what you've been exposed to, but I didn't know that the Christmas plants, the red ones, Pangeras, they're actually poisonous. These plants include poison ivy, poison sumac, poison oak, as well as other plants that actually can cause contact dermatitis, contaminate the patient, and deter the patient from scratching. Suicide bags, chemical suicide by toxic gas inhalation. This is a new trend that started a few years ago, well, many years ago. And when people that knew how to mix chemicals would lock themselves in the car, put a sign, do not open this because I'm mixing these chemicals and you might get hurt. And they would commit suicide like that. You inhale inhalation of helium or nitrogen concentrate in a bag over the head causes suffocation. Scene safety is critical. Evaluate the room and contact the fire department and treat the patient for toxic inhalation. Drugs and alcohol emergencies. Significant medical problems are associated with drugs, overdose, and withdrawal. Problems include altered mental status and respiratory depression. Patients abusing drugs or alcohol can actually be unpredictable and violent. Drug abuse, self-administer of a drug is a manner that is not in accord with approved medical or social patterns. An overdose emergency that involves poisoning by drugs or alcohol. You might actually get a withdrawal from some of these drugs, specifically the most common ones are like marijuana, uh, LSD, and all these other ones. So a period of abstinence uh, from the drug or alcohol to which the body has become accustomed to. You have stimulants, which bring up the body. You have amphetamines, cocaine, codeine, methamphetamines. Also, you have an increased alertness, elevated mood, loss of appetite, insomnia, increased blood pressure, and heart rate. Cardiac dysrhythmias, you have paranoia, hallucinations, agitation, violence, and seizures. Cannabis, dun dun dun. Basically, also known as hashish, marijuana, or THC. You have euphoria, decreased inhibitions, and you have dry mouth, or dry mouth and then discoloration. Okay, narcotics and opiates. You have codeine, heroin, morphine, oxycodone, and opium and methadone. Sorry. Drowsiness, lethargy, respiratory and depression, constricted pupils, nausea, and constipation. Depressants, basically, the depressants are set up as sedatives. You have alcohol antihistamines, barbiturates, and benzodiazepines. Now, what do you mean antihistamines? Well, Benadryl. Benadryl is an antihistamine, and actually, we give it to certain people, it puts them to sleep. It slurred speech, drowsiness, and coordination, impaired thinking, and respiratory depression and respiratory circulatory failure. Hallucinogenics, what's DET, DMT, LSD, or mescaline, which is mushrooms, MDA, PCP, or STP. Motor disturbance, anxiety, paranoia, delusions, illusions, hallucinations, poor perception of time and distance, psychosis, feedback, rage, and violence. Inhalants, aerosols, propellants, gasoline, kerosene, glues, lighter fluids, uh, correction fluids, the little white ink, anesthetics, propane, toluene. You have excitement, euphoria, giddiness, and loss of inhibitions, aggressiveness, delusions, drowsiness, hallucinations, and their patients are very erratic. Habitual alcohol abusers. Alcohol is a central nervous system depressant, which in large doses can actually cause unresponsiveness or death. Alcohol intoxication plays a role in motor vehicle collisions, drug overdose, homicides, drowning, and trauma. The scene size of primary assessment, secondary assessment, the physical exam, history, and signs and symptoms, and the secondary assessment. This should actually be reassessment, I'm sorry. Last one. Assessment-based approach, drug and alcoholic emergencies. These signs and symptoms make the patient of high risk or high priority. Unresponsiveness or seizures, inadequate breathing, abnormal heart rate, and vomiting with an altered mental status. Central nervous system stimulants, we have dilated pupil. So stimulus is going to dilate the pupil. Dry mouth and seeding, loss of appetite and sleep, tachycardia, tachypnea, hypertension, excitability, agitation, and being unresponsive. The depressants, what central nervous system depressants, causes you to have euphoria, drowsiness, and sleepiness, bradycardia, hypotension, decreased breathing rates and volumes, and dilated pupils that are sluggish to respond to light. And that's basically what we talked to somebody that they might actually develop photophobia, which it's not that they're scared to take photos, they're scared that light is actually affecting them. Narcotics, bradycardia. Oh, hold on, one back. Bradycardia, hypotension, bradypnea, cool, clammy skin, constricted pupils, lethargy, and nausea. And here you have a guy that actually has needle tracks. Assessment-based approach for drug and alcohol emergencies. Signs and symptoms: hallucinogens, dilated pupils, paranoia, anxiety, motor disturbances, tachycardia, flushed face, visual or auditory hallucinations, and poor perception of time and distance. You actually also have volatile inhalants, causes headache, nausea, vomiting, aggressiveness or depression, excitement, euphoria, drunkenness, erratic blood pressure and pulse rate, and swollen membranes of the nose and mouth. Assessment-based approach, do a scene size up, closely monitor the patient. Changes can actually occur readily. Calm the patient, protect him from from injuring themselves. Emergency medical care. Establish and maintain an airway and adequate ventilations. Maintain oxygenation and position the patient, not poison the patient. Position the patient. Drug and alcohol emergencies. Emergency medical care. Maintain the body temperature. Assess the blood glucose levels. Restrain the patient only if necessary, and reassess frequently. Maintain body temperature. Assess the blood glucose levels. Restrain the patient using only if necessary. Sorry, and reassess frequently. Specific poisons. Managing the violent or drug alcohol abuser. Drugs and alcohol can cause inappropriate or violent behavior. Okay. They can actually lead to unpredictable or violent behavior. There are special considerations for the safety of the crew, patient, and bystanders. Use a top-down technique. This technique is used to help decompress a potentially hostile situation. Focus on the patient and use a calm and reassuring voice. Explain what you're going to be doing to the patient that might actually be having some of these issues, and be non-judgmental. Okay, drug withdrawal, tolerance. Basically, if you take medications or drugs, your body tends to develop a tolerance, which you're going to need more and more and more. And then eventually you become dependent on it. So when you quit, your body's going to have a reaction. It's going to let you know you shouldn't have quit. Seizures can actually be part of it. Drug withdrawal, psychological dependence. This person is preoccupied with procuring the drug, stealing money, or whatsoever. Physical dependence, in the absence of a drug, results in physical withdrawal effect. Drug withdrawal. Drugs that produce physical dependence include narcotics, sedatives, hypnotics, barbiturates, cocaine, and marijuana. Drug withdrawal signs and symptoms begin when the next dose is missed, and peak about 48 to 72 hours later. The EMT should be aware of common signs and symptoms of withdrawal. The alcoholic syndrome. The syndrome consists of a problem drinking and addiction. Many forms of the drug can actually be abused. There also be dependence on other drugs. Alcoholics may actually begin drinking early in the morning or early in the day and drink secretly or go on drinking binges. Abstinence can result in withdrawal symptoms. Work and relationship may actually be deteriorated. Alcoholics are prone to injuries and medical conditions related to the alcoholism. Alcoholics are prone to hypertension, altered mental status, cirrhosis of the liver failure, and pancreatitis. Alcoholics are also prone to cardiomyopathies, problems with the heart, hypoglycemia, or slow blood glucose levels, upper gastrointestinal bleeding, uh, bone or bone marrow depression, subdural hematoma, peritonitis, seizures, and fractures. Withdrawals symptoms include insomnia, seizures, and tremors, uh, disorientation, confusion, anorexia, nausea, vomiting, hyperthermia, sweating, tachycardia, hypertension, hallucinations also. Stages of withdrawal symptoms, but stage 1 usually occurs about within 8 hours. Stage 2 is 8 to 72 hours. Stage 3 is as early as 48 hours, and stage 4 is 1 to 14 days. The delirium tremens, the funniest thing you can see is when these people think that they actually have snakes and ants on their body. Severe life-threatening complication occurs most commonly in 2 to 5 days. To the kitchen. To the kitchen. I was thinking about the kitchen. I'm hungry. 2 to 5 days after the last drink. Mortality rates 5 to 15% and lasts for about 1 to 3 days. You can develop tremors, restlessness, irritability, severe confusion, loss of memory, terrifying hallucinations, extremely high fever, profuse sweating, dilated pupils, and elevated vitals. Opioids. These are naturally synthetic or semi-synthetic agents that mimic morphine. Opioids are derived from the opium and actually act on the opioid receptors in the body. Like heroin is a type of opioid. It increases in size. It increases in abuse rates in the U.S. And that's what the issue we're hearing right now. Types of opioids have morphine, heroin, fentanyl, and cardinal. Signs and symptoms: CNS depression, respiratory depression, meiosis, which basically is constricted pupil, seizures or incoordination, hypotension, bradycardia, tachypnea, freckles in the lungs, and pruritus, hypoglycemia, and hypothermia. Opioids establish and maintain an airway, maintain an SpO2 level at greater than 94%, use a positive pressure ventilation if necessary, administer naloxone if protocols permit, 2 milligrams intranasal, 1 milligram for each nostril. Transport the patient with ALS received. In other words, you're going to meet the ALS unit and reassess the patient for deterioration or they're going back. Now check this out. Naloxone, which is Narcan. You're going to get into a syringe by sucking it out. Then you're going to get the atomizer. It's a mucosal atomizer device, which is this little triangle. You put it inside the nose and inject the fluid. And what it does, it spreads it like a vape, and it gets absorbed a lot faster. PCP, cocaine, amphetamines, methamphetamines, PABs, and MDMA. Each of these abuse drugs have a unique effects. Be familiar with each drug and know what is most commonly in your EMS area. PCP is a dangerous hallucinogen, significant psychological effects, which actually may last for years, store in the body fat, and actually and can actually be released over time. Cocaine may be inhaled, injected, or smoked. It's highly addictive, and the overdose can actually be very fatal. Amphetamines and methamphetamines, they are pill forms, smoked, injected, and snorted. You have CNS stimulation, can actually cause cardiovascular excitation, and hallucinogens or hallucinations, hyperthermia, and muscle rigidity. And it's also known as bath salts. You have synthetic designer drug, a central nervous system stimulant similar to the body of cocaine and methamphetamine. So bath salts, you have sympathetic effects, you have tachycardia, hypertension, hyperthermia, and seizures, altered mental status, paranoia, panic attacks, agitation, hallucinations, and violent behavior. MDMA, don't even ask me to pronounce this word. Also known as ecstasy. Psychoactive stimulant causing empathy, euphoria, and heightened sensation. Common to to rape parties. Overdose can actually cause death. Stimulatory effects in the central nervous system, memory impairment. Overdose can actually cause intracranial hemorrhage and death. Okay. General signs and symptoms: profound CNS stimulatory findings, involuntary eye movements, seizures, cardiovascular and respiratory emergencies, and intracranial hemorrhage. Emergency medical care. Protect yourself and the crew. Keep the patient as quiet as, or do not stimulate the patient. Check for injuries and manage as for other overdoses. Tetrahydrocarbonol, which is a principal psychoactive substance in cannabis, causes feeling of euphoria, can be smoked, vaporized, eaten, and used as extract, has limited medical applications, and it's gotten legalized in some of the states that we deal with. Texas still hasn't, but. So common findings include decreased short-term memory, dry mouth, tachycardia, increased blood pressure, and reddening of the eyes. Synthetic cannabinoids, which is chemically similar to THC and cannabis, they affect the brain more powerfully than marijuana. Tetrahydrocarbonol, which is a acute dose. You have recurrent nausea, vomiting, and abdominal pain and cramping. You have acute episode, lasts about 24 to 48 hours. And though these to be thought to be the result of a buildup of cannabinoids in the body itself. Recurrent nausea, vomiting, and cramping, abdominal pain, acute episodes last about 24 to 48 hours. And you have thought to be the result of a buildup of cannabinoids. I think I like that one. Syndrome criteria: long-term cannabis use, severe nausea, vomiting, abdominal pain, cyclic vomiting, relief of sympathetic with hot baths, showers, and subsiding of symptoms with cannabis stoppage. Once you stop, it'll go away. Medications overdose. An overdose may actually be intentional or accidental. Yeah, synergistic reactions can occur from the reaction in from interactions of medications. Medications commonly involved in overdose include cardiac medications, psychiatric medications, over-the-counter medications like pain relievers, antihistamines, herbal remedies, and dietary supplements. Puffing, which is basically when you get paint and you start reabsorbing it, is inhale poison with intention of getting high. Common involves the following substances. Products that actually contain toluene, paints, glue, gas propellants, and freon. And what you're going to know in some of these patients, they will actually have the circle of paint around their face. Okay. Let's take about a little break. I know there's been a lot, and then we'll continue in about 5 minutes. Now, this chapter 23, we're going to be dealing with abdominal, hematological, gynecological, genitourinary, renal emergencies, everything dealing with the lower abdomen. Okay. So abdominal pelvic pain has many causes and can actually be caused by a serious underlying conditions. Care includes managing life threats, making the patient comfortable, and transport. Hematological disorders are disorders of the blood and its components. Hematology. Gynecological emergencies can present with abdominal pelvic pain and vaginal bleeding. Some gynecological emergencies can be life-threatening. Yeah, renal disease is common. The EMTs are commonly encountering patients undergoing dialysis also. So abdominal structures and functions, a little bit over the anatomy. The abdominal cavity extends from the diaphragm to the lower pelvis. The parietal peritonitis lines like the cavity itself. Parietal cavity, visceral is organ or organ stuff. Abdominal quadrants and regions, we have divided into 4 different quadrants and 9 different regions depending on which route you take. So here the quadrants, you have the right upper, right lower, left upper, left lower, When it comes to regions, it's like a tic-tac-toe deal. Okay, in the middle we have the umbilical region, which is where the umbilicus is. Okay, you have on top we have the epigastric, then you have the left hypochondriac and the right hypochondriac, then the bottom, then of course you have the lumbar region, left and right. Then we have the right iliac region, the iliac being part of the bone, that name what it's called the bone itself, and left iliac region. Of course, you have the hypogastric right below the belly button. And we need to know what organs are hidden behind these areas. So we have different types of hollow organs, solid organs, and vascular structures. The hollow organs themselves are like the stomach, the intestines, the kidneys, and the solid organs would be like the liver itself, the pancreas, also be the spleen. The bladder would be considered a hollow organ and whatsoever. So hollow organs, the appendix, bladder, common bile duct, which is a tube that comes outside of the what do you call it? Gallbladder itself, sorry. Fallopian tubes, the gallbladder, intestines, stomach, uterus, and ureters. The solid organs would be the kidneys, liver, ovaries, pancreas, and spleen. And the major body vascular structures are the abdominal aorta and inferior vena cava. So I'm not going to go over these. You guys can read them yourself, but it just tells you what they are. Okay, abdominal pain, pathophysiology of abdominal pain results from these mechanisms: stretching, inflammation, and ischemia. Visceral, the types of pain, abdominal pain, you have visceral pain arises from organ and can actually be less severe, more generalized, very dull in feeling, and constant or intermittent. Once it starts becoming intermittent, it almost, you can always describe it as colicky. Types of abdominal pain, you have parietal pain, arises from the peritoneum, more severe, more localized, sharp, and it's constant. Referred pain is a visceral pain that is actually felt somewhere else. So it might be, let's say, your heart, but you feel it on your left arm. And these are the different types of visceral pains that we're gonna feel. Like the liver itself will give you a neck. And of course, this region right here, which is part of the small intestine region, but because it's lying right on top of it, um, it can also be the stomach itself. So you basically have all these different regions that you kind of suspect that you're gonna have issues with. I know that I had my gallbladder removed, and I had like a dull pain on my neck, and they didn't operate through my neck because that was a referred pain. Conditions can actually cause acute abdominal pain. There are several causes. Hospital care is usually required. Do not spend time at the scene trying to determine what's the exhaust cause. You basically just drive to the hospital. Okay. Some conditions may actually cause an acute abdominal pain, or it's a pain that starts all of a sudden. Peritonitis, appendicitis, pancreatitis, cholecystitis. And notice that itis means inflammation. So all these are kind of inflammation type of thing. Gastrointestinal bleeding, gastroenteritis, peptic ulcer disease, interstitial obstruction or intestinal obstruction, hernia, and abdominal aortic aneurysm. So peritonitis is called peritoneal inflammation. Signs and symptoms include abdominal pain or tenderness, nausea, vomiting, diarrhea, fever, chills, lack of appetite, and positive Markle test. So I'll explain later on what the Markle test is. Just remember there's a positive Markle test. And I think we talked about it before. Appendicitis is treated, untreated, the tissue can actually die and rupture. It can be common in children, and definite care is surgical. You need to do surgery for that one. Signs and symptoms for appendicitis: periumbilical abdominal pain localized to the right lower quadrant, nausea, vomiting, low-grade fever, chills, lack of appetite, and abdominal quadrant, the positive Markle test. Do you guys would Andrew? Do you remember what the Markle test is?
No, sir, but I think is it when you like try to touch their stomach and they stop you?
That's actually, believe it or not, that's not the Markle test, but that's rebound tenderness. The Markle test is when you have them stand on their tiptoes and you haven't fall down on the heels. I remember, I think that's what it is.
Yeah, now I remember. Yeah.
Cholecystitis associated with gallstones often occurs in patients between the ages of 30 and 50. More common in women. Without treatment, complications can actually occur. Signs and symptoms: upper middle to upper right quadrant abdominal pain, tenderness to the right upper quadrant, belching and heartburn, and nausea and vomiting. Gastrointestinal bleeding can occur, at any point in the gastrointestinal tract, classified as upper or lower. Many causes include ulcers, esophageal varices, and diverticulosis. Signs and symptoms of the bleeding: abdominal pain and tenderness, hematemesis, hematochezia, and melena. Hematemesis is vomiting up blood. Hematochezia is bright red blood coming out of your butt, and melena is dark stool. You have altered mental status, weakness, and syncope, tachycardia, and shock. Esophageal varices, these are engorged, weakened veins in the esophagus, can actually tear and cause you to have upper GI bleeds, commonly caused by heavy alcohol use or liver disease, and usually painless, but bleeding can actually be profuse. Your airway management can actually be challenging too, because if they vomit up blood and some gets absorbed into the respiratory tract, you're gonna be in trouble. Large amounts of bright red blood is hematemesis, no pain or tenderness in the abdomen. Have a rapid pulse because you're losing blood, so your body's trying to compensate. You have difficulty breathing, pale, cool, clammy skin with signs of shock, and jaundice, which is basically liver. Now, why would you be jaundiced in this situation? Well, what is jaundice, first of all? Yellow skin color. So the reason you might actually be jaundiced is because, remember what they said, alcoholism causes esophageal varices. So you have a damaged liver. Okay. And if you notice this, look at the liver itself. The blood vessel, I don't have the arterial one. Nah. Notice how the veins that come back, they get the liver first, and then they go to the esophagus, all these veins. So basically what happens is that because the liver gets damaged, it becomes a lot smaller. You have cirrhosis of the liver on the edges, and the container becomes a lot smaller. So the same amount of blood's going through there, but somebody's going to back up and cause varices. Endoscopic view of the esophageal varus itself. So it's just a big blood vessel that's actually engorged. And if you eat like a Dorito without chewing it completely, you're going to tear it off and you're going to start bleeding. Conditions can actually cause acute abdominal pain. Gastroenteritis may actually be chronic or acute, often caused by infection. Signs and symptoms: abdominal pain, cramping, nausea, vomiting, diarrhea, abdominal tenderness, fever, dehydration, and shock. Signs of shock in severe cases. Why? Because, well, you're bleeding internally. Ulcers: you have open ulcers in the stomach or beginning to the small intestine, may result in bleeding or perforation. And then ulcer, let's say it develops right here, and it's an area where there's no mucus on it, so anytime that acid hits it, it gets irritated. It might actually burst, and all your acid in the stomach starts going outside. Damage a lot of skin. This is basically an ulcer that you get to see on the small intestine. Conditions can actually cause acute abdominal pain. Signs and symptoms: sudden onset of left upper quadrant epigastric pain, nausea, vomiting, hematemesis, hematochezia, and melena. Signs and shock in cases of severe bleeding, and peritonitis in cases of perforation. Intestinal obstruction may actually include small or large intestine, may result from tumors, fecal compaction, or adhesions. And an adhesion, all it is that if you have surgery, the intestine is going to be attached. It's going to attach itself to fibrosis to the peritoneal cavity. So if you move, you're going to be stretching your, what do you call it, your intestine, because it's attached to the wall. Untreated may actually lead to sepsis, perforation, intestinal infarction, and peritonitis. Signs and symptoms of intestinal obstruction: abdominal pain, nausea, vomiting, constipation, abdominal distension, tenderness, prominent high-pitched bowel sounds, and diminished or absent bowel sounds. Hernia, basically a protrusion of the intestine through the opening or weakness of the abdominal cavity or abdominal wall. So your intestine pops out through that weakened section associated with increased pressure in the abdominal cavity and may actually become incarcerated, which basically means it gets trapped there and you start cinching off the blood supply to that piece of intestine that's popping out. Signs and symptoms: abdominal pain with lifting or straining, fever, rapid pulse, tender mass at site of the hernia, and signs and symptoms of intestinal obstruction. Abdominal aortic aneurysm, which is a AAA, it's a weakened or balloon section to the aorta itself, may rupture, and most common in men over 60 years of age. And those, you die. If you don't catch it within time, like if it's ballooning out like this, you're gonna see signs and symptoms. But if it just happens all of a sudden, it balloons out, and if it bursts, you're gonna lose all your blood. And this is basically what the aortic aneurysm looks like. You have a weakened section, and blood starts getting trapped in there and ballooning the area out until it tears. Signs and symptoms: gradual onset of lumbar, groin, or abdominal pain with rupture, sudden onset of severe, constant pain of the lower back, flank, pelvis, described as a tearing sensation. And you might actually also develop testicular pain. Signs and symptoms: nausea, vomiting, mottled or spotty abdominal skin, pale, cool, clammy, cyanotic skin in the legs because blood's not going down to the legs anymore. Absent decreased femoral or pedal pulses, skin below the waist may actually be cyanotic, cold, or actually mottled itself. So you're gonna have like blotches like a giraffe. Abdominal, do not palpate the abdomen, because you palpate, you're putting more pressure on it, might actually burst. Do not continue to palpate the pulsating mass. Assess for shock and transport to the hospital right away. The condition can actually cause acute abdominal pain, vomiting, diarrhea, and constipation. Associated with many acute abdominal disorders, can actually cause abdominal pain, may lead to dehydration, serious enough to actually cause shock. Pediatrics questions: infants and small children. Has a child been more irritable than normal recently? Can you console the child when they are crying, or has a child had poor feeding habits recently? In the old people, the geriatric patients have decreased perception of abdominal pain, may actually wait longer to seek medical care. Immunocompromised patients have a poor inflammatory response to abdominal conditions. Bariatric surgery patients are at risk for ulcers, perforations, and obstruction of the bowel. Now, what's a bariatric surgery patient?
Obese or super big person.
Yeah, these are the guys that actually, believe it or not, have surgical procedures to make their stomachs a lot smaller. Assume the problem is a potential life-threatening condition. You have low blood pressure, basically syncope, pale, cool, clammy skin associated with abdominal pain indicates a serious condition. Abdominal pain lasting for more than 6 hours is an emergency. Take standard precautions. Look for mechanism of injury if they got hurt. Look for indications of bleeding, vomiting, and or medications used to relieve abdominal pain. Primary assessment from the general impression, from a general impression, patients with abdominal pain may assume a guarded position. Ensure that there's an open airway. Be alert for vomiting and assess or assist ventilations if it needs to be. Primary assessment, check for circulation, pulse, skin color, temperature, and condition. Categorize the patient as high priority if they exhibit the following conditions, or the following: poor general impression, unresponsive, responsive, not following commands, shock, or severe pain. As the following OPQRST questions, if the patient has any allergies, if the patient has past medical history of abdominal problems, or when the patient last ate or drank. Has the patient also had appetite changed? What was the color of the patient's last stools? Has the patient had difficulty urinating? What is the patient doing when the distress started? Now, why would you ask him? Are they having problems peeing?
Like problems like actually letting the urine out, or just like pain when they pee.
Well, basically, look, I'm gonna tell you the thing about it. If you're dehydrated or you're bleeding internally, not the blood is not going to the kidneys anymore, so you're not filtrating anything out, so you're gonna have problems bleeding. I mean, peeing. Get it? So that's like a telltale sign. Secondary assessment: inspect the abdomen, palpate the abdomen in all 4 quadrants, and begin palpations with the least painful area. So remember, at the belly button, you separate into 4, and then from there, you just press down and let go. But try to feel what's behind that tissue. Assessment-based approach, acute abdominal secondary assessment. The abdomen normally should be soft and non-tender. Assess for voluntary guarding, and rigidity. Palpate the masses and assess vital signs. Be alert for signs of shock. Associated symptoms, signs and symptoms: you have tenderness, anxiety, fear, guarded position, or it's a fetal position, rapid shallow breathing, and rapid pulse. Associated signs and symptoms: blood pressure changes from pain or shock, nausea, vomiting and diarrhea, abdominal rigidity or guarding, distended abdomen, and fever or chills. Belching or influence, changes in bowel habits or urination, signs of symptoms of shock, and signs of internal bleeding, which is basically shock. Emergency, and you also got to look for melena, hematochezia, and hemoptysis. Keep the airway.
You just ask the patient if they've been having like dark stool, if you're looking for melena.
The what? I'm sorry, what?
Do you just ask the patient like the color of your stool that like it's been recent?
You can ask them. And it's very important because if it comes out very dark, that means they have possibly an upper GI bleed. If it comes out bright red with tinges, then with tinges of blood, that's hematochezia, which basically they're actually having an active bleed into the large intestine or small intestine. So yeah, I mean, that's what they pay you for, to ask these embarrassing questions. I mean, you're gonna have to ask the little girl, "Are you sexually active?" Because you never know, that might actually be causing the emergency. Maintain an SpO2 level greater than 94% and administer nothing by mouth, because they might have to go into surgery. Okay, emergency medical care. Acute abdomen coma, reassure the patient, treat for shock if present, and initiate transport. Hematological emergencies are basically bleeding emergencies. Blood. Hematological problems may actually arise to encounter pre-hospital care include anemia, sickle cell disease, or hemophilia. Anemia is a decrease in red blood cell volume, may actually be chronic or acute, and a decrease in oxygen carrying capacity may cause patient to be pale and easily fatigued with shortness of breath and on exertion. Sickle cell anemia, a hereditary disorder, more common in African Americans, and those of Mediterranean, South and Central America, and Middle Eastern origin. And sickle cell, believe it or not, was the body's way to actually deal with malaria. The body's common patterns of sickle cell consist of all the following, which are painful, and the following: bone crises, acute chest discomfort, abdominal crises, and joint crises, because blood gets stuck in there. Okay, signs and symptoms of sickle cell crises: bone and joint pain, fever, chest pain, shortness of breath, fatigue, and pale skin. Priapism, jaundice, tachycardia, ulcers in lower legs, sudden blindness in one eye, excessive thirst, and frequent urination. Emergency medical care. Ensure an adequate airway, breathing, and circulation, and maintain an adequate oxygenation. And hemophilia, blood clotting is impaired, in other words, you can bleed to death from a little cut. When normally is considered minor bleeding, can actually be an emergency for hemophiliacs. Use normal methods to control bleeding, but be aware that bleeding control is often difficult. Gynecological emergencies deals with the female reproductive system. Signs and symptoms include abdominal pain, vaginal bleeding, and abnormal discharge. Some gynecological problems are life-threatening. So basically, the reproductive system consists of the vagina, the ovaries, the fallopian tubes, and the endometrium, which is the inner lining of the uterus that sheds off and causes you to actually have a menstrual cycle. So basically, the endometrium will actually be found in this region right here. And it sheds off. But when there's inflammation, the cells that produce that blood to sustain the baby, you get a case of endometriosis. Okay. Gynecological conditions that actually may cause abdominal pain or bleeding: sexual assault, vaginal bleeding, dysmenorrhea, ovarian cysts, endometriosis, endometriosis, I'm sorry, arthritis, and this is endometriosis. Pelvic inflammation disease, sexually transmitted diseases also. Sexual assault, follow protocols for reporting sexual assault. Sexual assault may actually has physical or psychological effects. It may actually include physical effects of sexual assault, include traumatic injuries, genital rectal swelling, bleeding, and pain, sexually transmitted diseases, or pregnancy. Psychological effects: anxiety, inappropriate feelings of guilt, flashback nightmares, and emotional withdrawal for sexual assault. follow these sexual assault guidelines. Do not allow the patient to change or bathe or comb their hair or whatever, because you might get rid of evidence. Do not cut holes or tears in the clothing. Don't touch or change the crime scene. Don't clean the wounds and transport clothing with the patient herself. Uh, don't be judgmental. Provide safe environment, respect confidentiality and privacy, and ask only questions that are pertinent to patient care, not what happened. Vaginal bleeding, non-traumatic. Bleeding may actually be related to menses or medical problems. The most common cause is spontaneous abortion. Okay, signs and symptoms of spontaneous abortion include lower abdominal and pelvic pain, abdominal tenderness, vaginal bleeding, rapid pulse, and signs and symptoms of shock. So menstrual pain is a strong uterine contraction that actually causes severe pain during menstruation, and it's called dysmenorrhea. Dys basically meaning difficult. Dysmenorrhea is a common cause by hormonal imbalances in the system. Menstrual pain, strong uterine cramping that actually causes severe pain during menstruation. It's called dysmenorrhea. Why would you want to talk about that one? The ovarian cysts. I'd be surprised how many ovarian cysts I saw just by doing ultrasounds or just by symptomology. These are fluid-filled sacs that form on the ovary itself. Okay, and remember, the ovary will release an egg to the fallopian tube so it can try to see if you can get impregnated. Well, these are fluid-filled sacs that cause pain. Signs and symptoms include unilateral abdominal pelvic pain, abdominal tenderness, vaginal bleeding, and pain during sexual intercourse or bowel movements. Endometritis, which is inflammation in the endometrium commonly caused by infection. Signs and symptoms include abdominal pelvic pain, tenderness, fever, abdominal distension, vaginal bleeding or discharge, and discomfort during bowel movements. Endometriosis is a sign. The signs and symptoms include abdominal pain and tenderness, dysmenorrhea, now it's heavy periods, vaginal bleeding, pain during sexual intercourse, or bowel movement. Excuse me. Gynecological conditions, pelvic inflammatory disease, also known as PID. Infection in the female reproductive tract. Signs and symptoms include abdominal pelvic pain or tenderness, abnormal vaginal discharge, fever, chills, nausea, vomiting, anorexia, irregular vaginal bleeding or cramping, and pain during sexual intercourse. Sexually transmitted diseases, infections contracted through sexual contacts. Most sexually transmitted diseases are caused by bacteria, viruses, parasites, or fungi. The most common are chlamydia and gonorrhea. So basically, these are the different, what do you call it, sexually transmitted diseases and what they actually are. And you can actually read up on this, like gonorrhea is a bacteria, syphilis is a bacteria. The cancro is also part of the syphilis, which is a bacteria whatsoever. Sexually transmitted disease signs and symptoms include abdominal pelvic pain or tenderness, normal vaginal discharge, nausea, vomiting, fever, chills, irregular vaginal bleeding or cramping, pain during sexual intercourse or urination, genital itching, redness or swelling, and lesions or ulcers themselves. Vaccine size-up. Take standard precautions, determine the nature of illness and the mechanism of injury. If it appears to be a crime scene, contact law enforcement so you can let them know. Primary assessment, determine the patient's mental status, ensure an open airway and adequate breathing, administer oxygen to maintain an SpO2 level greater than 94%. Pay attention to perfusion status. Now it's their blood pressure is at normal, and then control any external bleeding. Primary assessment categorize this as high priority or low priority. Poor general poor general impressions, unresponsive, responsive, not following commands, severe pain, shock would be actually be a high priority patient. The secondary, protect the privacy and modesty of the patient, be compassionate and professional, obtain a history and vital signs, and perform a physical exam. Ask the following: what are the signs and symptoms? What are the signs and symptoms? I'm sorry. Have the signs and symptoms gotten better or worse? How long have the signs and symptoms been present? And was there an onset sudden or gradual? Was it start slowly over time, or was it just all of a sudden? What was the patient doing at the onset? Does the patient have allergies? When did the patient last eat or drink? What are the patient's medications? And are they using contraceptives? What is the patient's past medical history? What was the patient's last menstrual period? Is there any vaginal bleeding? If so, how many menstrual pads have been saturated? Is there a possibility of pregnancy? How many pregnancies has she had? Is there any vaginal discharge? Has there been nausea or vomiting? Is there pain with urination? Vaginal discharge and other pain, abdominal pelvic pain or tenderness, nausea, vomiting, fever, chills, genital itching, redness or swelling, or signs of shock. Do a physical exam and examine the abdomen. Ask if there's any vaginal bleeding, clots, or tissue. Obtain a baseline vital signs. Emergency medical care. If trauma is involved, consider spine motion restriction, maintain a patent airway, maintain adequate oxygenation, control external bleeding, and place the patient in a comfortable. Okay. Organs of the female reproductive system are separate from those of the female urinary system. In males, some of the structures are shared. Patients with genital urinary or renal conditions may actually experience abdominal pelvic pain. Let me see, hold on. I just want to check something. Okay. Okay. The urinary system actually produces and stores and eliminates urine. The kidneys filter the blood and excrete waste products into the urine, and the kidneys also play a role in pH regulation and blood volume and pressure. The ureters actually carry urine from the kidneys to the urinary bladder. The urinary bladder stores the urine until it's eliminated through the urethra. In men, the urethra serves both urinary and reproductive functions. So these are the kidneys, the ureters, the bladder, and below the bladder will be your urethra. And this here right here is the urinary bladder, and then you go into your urethra itself. So key things, urinary tract infection, kidney stones, or kidney failure might actually be some of the emergencies that you deal with. The urinary tract infection is most frequently caused by bacteria that enter through the urethra, more common in women and the elderly, diabetics, and patients who are immobile or catheterized. May actually affect the urethra, bladder, the ureters, kidney, and in men, the prostate. Signs and symptoms include abdominal pelvic pain or tenderness, blood in the urine, cloudy urine, strong odor of urine, pain, burning, with urination or intercourse, frequent or urgent need to urinate, which is called urgency, genital flank pain, and fever or chills. Kidney stones develop in the kidney itself and or might actually be pushed down the ureters. A family history kind of dictates you're going to have them. The other thing I heard is if you drink a lot of Topo Chico, so I don't know. Stones can actually cause severe pain. If untreated, stones can actually lead to obstruction and kidney damage. Signs and symptoms include abdominal pelvic pain or tenderness, colicky, severe back or flank pain, groin pain, fever, chills, abdominal urine, abnormal urine color, pain with urination, frequent or urgent need to urinate, and nausea and vomiting. The kidneys do not adequately filter with kidney failure waste products. So the kidney failure may actually be an acute or chronic situation. Acute kidneys injury occurs over a period of days, and kidney failure may actually be maybe reversible if you catch it on time. Chronic in kidney failure, you have chronic renal failure occurs over years. Symptoms progress from mild to severe. Diabetics and hypertensive patients are leading causes. Conditions is not reversible. The patient requires dialysis of a kidney or a kidney transplant for survival. Complications from kidney failure, pulmonary edema, cardiac tamponade or pericarditis, electrolyte and other metabolic problems, cardiac dysrhythmias, congestive heart failure, hypertension, or infections. Signs and symptoms they include for kidney failure is blood in the urine, altered mental status, edema of the feet, ankles, and legs, increased or non-urine output, hypertension, anorexia, and tachycardia. In hemodialysis, blood is removed from the body and recirculated through the machine that actually filters all the toxins out. Access is through a shunt, fistula, or porter or graft. In peritoneal dialysis, fluid is placed in the abdomen by a tube and is actually filtered out there. The fluid is then drained from the abdomen. The process can actually be performed at home. And this is what we call a shunt. It's a fake blood vessel. What happens is that people with diabetic might actually have one or two, but with time, if you need a kidney dialysis, they're going to put one of these because it's plastic and they can actually poke it as many times as they want to actually be able to transport blood. I mean, not transport, but get the blood out and get it filtered in the dialysis. And here's a picture of one of them. You have one of these guys, do not take the blood pressure right there. Okay, so it's a shunt right there, and this is the peritoneal. Now, complications include hemorrhage, hypotension, muscle cramps, peritonitis, nausea, vomiting, infection of the access site, irregular pulse, cardiac arrest, and difficulty breathing. Dialysis, complication of missed dialysis. You get weakness and pulmonary edema. Dialysis emergency management support airway, breathing, and circulation. Provide oxygen as needed and stop bleeding from the access site and position the patient and transport. Urinary catheters. Urinary catheters drain the urine from the bladder, and indwelling Foley catheter is the most common type, and patients are prone to urinary tract infections and device malfunction. Okay, so basically this is the way the catheter goes into the urethra, okay, into your bladder, and then they inflate the bag so it doesn't get pulled out. Okay, this is basically the way they actually have a tube and they just have a bag that's holding their urine. Catheter management, note any unusual color, bleeding or swelling or odor. If possible, drain the bag before transport and record the amount that you drained out. And the color, don't forget the color. Do a scene size up. Ensure that the scene is safe. Take all set of precautions. Determine whether the patient has been injured or is suffering from a medical illness. Primary assessment, former general impressions, mental status, airway, breathing, circulation, oxygenation, and circulation. Patient is a high priority for transport if they actually exhibit any of the following: poor general impression, in which they look like shit; unresponsiveness, responsive, not following commands, severe pain or shock. Secondary assessment, protect the privacy and modesty of the patient, be compassionate, non-judgmental, obtain history, and obtain vital signs. The history, look for signs and symptoms of what, when, and how fast. What was the patient doing before this happened? Does the patient have an unknown allergy? When was the patient's last oral intake? What medications are they on, and what is their past medical history? You can also ask, what was the patient's last menstrual period? Is there any genital pain or discharge? Is there any changes in the urine? Does the patient receive dialysis? Do they have any abdominal, pelvic, or flank pain? History, has there been any nausea, vomiting, signs and symptoms of abnormal color, consistency, or odor of urine, abdominal, pelvic pain or tenderness, and nausea and vomiting? Secondary assessment, signs and symptoms: fever, chills, syncopal or altered mental status, pain or burning during sexual intercourse, flank, groin, or back pain, frequent or urgent need to urinate, and blood in the urine. Signs and symptoms: edema of the feet, ankles, legs, hypertension, anorexia, tachycardia, and signs of shock. Okay, assess the abdomen, assess other systems such as the lungs and cardiovascular system also. If there's a catheter, observe the amount and the appearance of the urine. Take and record the vital signs also. Emergency medical care, establish spine motion restriction if needed. I'm sorry, I don't know why it goes back. Maintain the airway and ventilation, maintain oxygenation, control major bleeding, and position the patient according to the condition that they might actually be going through. Assessment based approach, emergency, calm and reassure the patient, transport, and do a reassessment depending if it's a dire emergency every 5 minutes, if it's not, every 15 minutes. Okay. You guys have any questions? Or do you have any questions?
No, sir.
Okay, so I'm gonna go ahead and on Wednesday. Are you still there? Yeah. You disappeared.
Yes, sir.
There you go. So I'm gonna go ahead and stop today, and I think just a reminder, test is coming up, I believe, next week.
Next week
Actually, no, hold on. Yeah, test 2, July the 12th. Okay, so it's on next, I believe, Wednesday or Friday. I can't remember, but it's from chapter 7 to 26. And it's gonna be like maybe 50 to 100 questions. It depends on the mood that I'm in. just don't forget to do your assignments and check the videos that I've given you, so you can start studying for it. So on Wednesday, we're going to be covering. Oh, I'm sorry. Next, yeah, this Wednesday, right? Yeah, chapter 25 and 26, which is submersion and psychiatric. So good luck with that.